Hello?
Yep, you can go ahead and start.
And your participants can hear you.
Oh, thank you. Okay. Okay, hello. My name is Olive Young, and I am going to be the moderator for this session. I'm delighted to be welcoming Dr. Virginia Vandal Walker, correct?
Yes.
To be our presenter. So I am part of the, I'm doing this as part of the CASN Research and Scholarship Committee, and I'd like to welcome you to this session, as I said earlier. The reason I'm doing this is because I was a 2016 recipient of the Pat Griffiths Scholar Award, and this is an award that is given to nursing scholars, and I would highly recommend that you apply for this award this coming year. All the details are on the website. Now, I'm not sure if many of you are familiar with the concept of lunch and learn, where faculty members come together during their lunch hour to share with one another projects they are working on, or just to talk and discuss methods, successes, and challenges. This webinar series is intended to serve as inspiration and a networking opportunity for participants while recreating the collegial feel of the lunch and learn, but through virtual words. In this third session, we will hear from Dr. Virginia Vandal Walker, Associate Professor at Athabasca University, on the strategy for patient-oriented research. The Canadian CIHR-led strategy for patient-oriented research, or SPOR, was initiated to promote greater research engagement with patients at all stages of the research process in order to stimulate the impact of research on improving patient and systems outcomes. This webinar includes an overview of the SPOR and Alberta SPOR initiatives with a focus on the what, why, when, who, and how of patient and researcher engagement in healthcare. After Virginia's presentation, we will have time for questions. To submit a question for the presenters, please use the question and answer function on your screen. Once you have finished typing your question, please don't forget to hit send. Now, just to tell you a little bit about Virginia, she is an associate professor with the Faculty of Health Disciplines at Athabasca University and an adjunct associate professor with the Faculty of Nursing, University of Alberta. And she's also has her PhD from the University of Alberta. Her nursing experience is over 40 years and includes 20 years in Canada's North as an outpost nurse, director of nursing, and practical nurse program director, and 20 years plus as professor with Athabasca University. She is also the recipient of the Craig Cunningham Memorial Award for Teaching Excellence in 2014 and has been chosen a Carna Centennial Award 2016 recipient in recognition of personal and professional contributions which inspires others. That's beautiful, Virginia. So she started this position in 2014, and so I'm delighted that you're here to facilitate this lunch and learn. So over to you.
Thank you, Olive, and thank you all of you online who are listening. It's a real honor, privilege, and I'm excited to be presenting about this to a cross-Canada audience because this is a cross-Canada initiative, and we're struggling to get the word out to as many people as we can. And nursing researchers seem to not be as tied into this initiative, probably because they do a lot of qualitative research and think they are already engaging with patients, but we're talking about a different level of engagement than just as the participant. So without any further ado, I will get started. So I'm going to give you a little outline. I'm going to talk about a background of SPOR, definitions, patient and researcher engagement in health research, give you time for a couple of questions. I think a couple of questions would be the most that we could entertain at that point. Then go on to talk about the Alberta SPOR support unit and the patient engagement platform. Then some questions as well, and provide you with some research examples. We will also be talking about ethics implications, practice and science of patient and researcher engagement in health research, and implications for health disciplines education, followed by the final questions and answers. So, in terms of SPOR, I don't know how many of you have heard of it. And you could raise your hand if you have, because Olive can see you raise your hand. I'm full screen here. But it was initiated by the Government of Canada in 2011 through the Canadian Institutes for Health Research. It's a 5-year, multi-million-dollar strategy. Each province has their own SPOR unit, all configured differently, all with different budgets, depending on who all joined in to provide funding, matched funding to CIHR. And it was influenced primarily by what was happening in the UK and has happened over the past 20 years, as well as in Australia and the US. These influencing initiatives in UK, it's called Involve, and that was established back in '96. To support active public involvement in the National Institutes for Health Research, public health, and social care research. And they really are the drivers of this initiative even here, but we have our own Canadian way that we are enacting this. The U.S. has PCORI, and that is the a government initiative right down from the federal government. It's located in Washington, and they fund patient-oriented research. It's an independent nonprofit, and they don't do the support for researchers and patients that we do in Canada. Our focus is quite different. There are support units across Canada. I don't know where everyone is joining in from, but I thought I would provide that information for you so that if you don't know about the unit and want to find out, these are names of the heads of those units, and you would be able to connect with them to find out more. So what do we mean when we say patient? And when I say mean, I mean SPOR nationally. We mean anyone, current and past patients, family members, or other persons with experience of the health system. So any member of the public, and it includes healthy people. What is patient-oriented research? POR, and you'll hear that acronym a lot. It's a continuum of research that engages patients as partners. It focuses on patient-identified priorities in order to improve patient outcomes, conducted by multidisciplinary teams in partnership with relevant stakeholders, and aims to apply the knowledge generated to improve healthcare systems and practices. Before I go on, I want to make a brief mention of the word patient. Many of us have been unhappy with that term being chosen as the one to depict all those people that we're speaking of. Many of us have used the word public instead, but at this point in time, that is the way all the documentation is written, and so we will use it, but we fight strongly against it. At meetings when we have patients joining with us, they say they don't like that word. I'm no longer a patient. Just so you know that there's a lot of dialogue going on out there, and we do think that we will see a change in that in the future. Just in case anyone's upset about it, because I know I was, even when I first started in this role. So the focus of patient-oriented research is putting patients first to make sure that health research is relevant to patients' concerns, to improve the quality of research, to make sure the money spent on research is looking at topics of interest to patients, and to more quickly share the research findings with everyone who is affected so that there can be improvements in the quality of care. Key messages: engaging patients as partners is the aspirational goal of POR. The patient engagement platform helps make the connections. That is our mandate, is to do that. So we're involved in a huge culture shift and movement from traditional health research. And even though those of us in nursing know that we have connected a great deal with our participants in research, this is really focused. It isn't focused on medical research, but medical research is probably the biggest use of SPOR at this point in time, more so than nursing. Beyond patients as participant subject, research co-creation with patients is possible and already happening. Patients as subject participants still incredibly valuable and are needed. And interestingly enough, we weren't considering patients as participants as being part of being engaged, and yet we did a survey of Albertans, And when we asked them what they wanted to learn and know about health research in Alberta, they want to know, the majority of them wrote they want to know how to get involved in a clinical study. So that was a shock to us. We should have thought of that, but anyway, it did change our thinking in terms of what is encompassed in patient engagement. So it's doing research with patients and not to or for patients. So are there any questions so far about what I've presented? And if not, I think I'll go forward. Do feel free to type in your questions at any time, because I do have breaks periodically where we will look at the questions and answer them as we go through, because this presentation covers a lot of ground. So who are the experts? I'm talking probably to nurses, and you know this, that patients, members of the public are considered experts. This was something that when I was doing my master's back in the last century, we were talking about that. It's now come into the lexicon in medicine now. But the researchers and clinicians, of course, are experts in their knowledge and experiences about their particular field of study and research. But patients, members of the public, are experts based on their knowledge from lived experience with the disease, health condition, or health-related situation. Together, you can get a different perspective that gives you that 180 view. So what is meaningful patient engagement? And it's not just patient engagement, it's patient and researcher engagement. This is a fine-tuning that we have done from our platform, because engagement is not a one-way street. It has to go back and forth. It's a relationship, and it's all about building that relationship. So it has to be mutually beneficial partnerships. Both sides have to feel they're getting something out of this. And for it to be meaningful, both parties have to be respected and be respectful. Both have to listen, consider other points of view, commit to learning, such as the crazy languages that we use in some of our medical research, and about research terminology. But we have to try, as well as researchers, to understand the patient's point of view and the patient's language that they might be using. We need to clarify the roles and clarify the approximate time commitment, and communication needs to be ongoing throughout the project. It can't just be at the beginning when you have some patients involved in looking at a survey and how to develop the survey better, and at the end. You're going to lose them in between if you don't maintain and continue that relationship, that communication with them. So I have a quote here, evidence of meaningful engagement from a parent. When I was first offered the opportunity to be a part of the Letters Project Parent Advisory Group, I was excited and a little confused. I have no research or healthcare background and was completely unaware that patient-oriented research was a thing. I was beyond nervous. Will my voice go unheard? Will I be judged for my lack of knowledge? Upon arrival, I was relieved of my worries as I was greeted warmly by the team. The social barriers I expected were non-existent in that room. My personal experiences were met with genuine care and interest by the team members, and my suggestions were implemented and built upon. Now, this is Laura Saunders, and we have published the letter that she wrote me about being involved in this particular project, and it has been published in Pediatrics, one of the top-tier journals out there, and they were profoundly influenced, or not, they just felt that her words were so profoundly influencing in support of what can happen when you involve patients in the research process. So when to engage? Patient partners and researchers can engage at any or all stages in governance and in the evaluation of patient and researcher engagement. So even if you're at the translation dissemination end of your project, you can bring patients in to help you with that. You can bring them in at the very beginning just to help you with the idea generation. It's wherever you're at, they can benefit you and the project by being involved. So this schematic is one that I developed based on my experiences over the last 3 years, getting feedback from researchers, from patients. It was originally an adaptation of the IAP2 framework. I don't know if you know it, but that framework was very top-down, very one-sided, and it just left a lot to be desired, and I didn't feel comfortable using it as a framework to explain patient and researcher engagement. So this is what I've come up with. It has been published in that pediatric journal, as I mentioned, and we have 3 more publications, well, one that's just been published last week and 2 more under review. But basically, there are these levels, and as you get deeper into the levels, you will see lead support. This is where there are patients who are leading the research project, and the researchers are supporting them in doing that, as opposed to the very early levels of engagement where you're just learning about the project, or you are being informed about the project, or you are informing the researchers about things about the project. So it is wordy. I'm sure you can read that at your leisure, but the whole idea is that more time, more knowledge, and more funds are needed as patients and researchers engage together at deeper levels. Because of course, if you're going to collaborate, you're going to be involved, it's going to take more time, and we are championing the compensation of patients for their time in being involved at those higher levels or deeper levels. So how deeply to engage? Well, it's up to the researcher. How prepared are they to engage with patients at a collaborate level? Maybe their abilities to engage are not fine-tuned enough, and so that's where the patient engagement platform comes in. We have training opportunities and mentoring opportunities to help teams build and work together. Credibility and legitimacy come up in patient engagement because the people involved need to be credible with the researchers, so you don't want someone with arthritis necessarily informing researchers about heart disease. So that's part of that piece, as well as the legitimacy among the patient public. Is this person who might be a spokesperson for our disease legitimately supported by us as being someone that can represent us well? And so you see, as legitimacy increases and credibility increases, it goes from personal opinion to being a member and driver. So that's an important consideration. Are there any questions up to this point? Okay, so I'm going to go into an overview of the Alberta SPOR support unit. And support stands for Support for People and Patient-Oriented Research and Trials. Alberta was the first SPOR unit established in the country. And as a result, we can't learn from those who've come behind to the same degree that they're learning from us. We're sticking our necks out a lot and finding out, well, we could have done this better, or, gee, we did a great job on this, and everybody's following our lead. Anyway, the support units are provincial, territorial, regional service centers. The vision of the support units is to advance the knowledge to improve patient health and health care. The goal is to increase the quality and quantity of patient-oriented research, and the term is 5 years, from 2015 to 2020. You heard me say that we were the first out of the gate. We did receive our funding before anyone else, but it took us a good 1.5 years to get ourselves organized before we received any of those funds. The value in Alberta is $48 million. Matched federal provincial, so 24 Alberta Innovates and 24 million CIHR. Every province is different. I know the BC just received, in the past 6 months, they received their funding, and they received $80 million in funding. And they have many, many partners. that are funding partners. We only have 2 funding partners in Alberta, CIHR and Alberta Innovates. The other partners who were co-signatories on the application were Alberta Health, Athabasca University, University of Alberta, Calgary, and Lethbridge. Oh, excuse me, Athabasca was not a signatory. They are considered partners now because I work for them, and they pay all our salaries. So, and we were the first unit with a PE platform, and I think we're still the only unit with a PE platform that has staff and budget. And that is an important factor, because with that staff and with the budget, we are able to initiate a number of initiatives which we've done, and that has been very valuable nationally because we share what we do across the country. Without the budget, we wouldn't have been able to move things along as well as we've had, and there have been some who say, though, PE, patient engagement, should just be a component in all the platforms. So there was some discussion about that in the early days, and that's the way some of the units do it. They don't have a patient engagement platform. They have a person who has influence on all the platforms. So we did it very differently here. This is our governance structure, just to show you, and I wanted to point out at the bottom that we are here for the SPOR networks, and I think nationally those are the Strategy for Patient-Oriented Research networks. There's, I can't remember the number, the latest number of them. I think there's about 8 now. And then in Alberta we have Strategic Clinical Networks. That's from our Alberta Health Services, and we're there to provide support to them, to patients, and other researchers and teams. And what happens is you're not seeing that box put on a lot of the org charts for the different units. But know that that money, that there are funds, there is support there, even if you're an individual researcher who isn't part of a network or a, some kind of group that would fit into this. And when this was first presented to me, it looked like it was only for medical researchers, but qualitative researchers can get support as well. So it's there for everyone, not just for medical research. They just get more airtime, okay, at this point. So the platforms, these are the platform leads on the left-hand side. I don't know if you can see that. Maybe I should go back. I don't know if any of you know these people, but Data Platform and Services is Dr. McAllister at the U of A. Methods, Support, and Development is Dr. Kwan, U of C. Pragmatic Clinical Trials, that's a co-lead situation, Dr. Hill and Dr. Riche, U of C and U of A respectively. Myself with AU, Dr. Ross Tsuyuki, U of A. Dr. Lisa Hartling for Knowledge Translation, U of A, and Career Development is another joint lead situation, Dr. Marilyn Hebert, U of C, and Dr. Dean Urich, U of A. So 5 platforms provide individualized services to researchers. That's the data, methods, research consultation, KT, and patient engagement, and to patients. Patients engagement provides individualized services to patients as well. 2 platforms build capacity in Alberta's research community by providing career development and training opportunities. And actually, the patient engagement promotes the capacity building of researchers and Albertans related to knowledge about research and engagement practices. I want to say here that every unit across the country is configured differently. Some might have 3 platforms where they collapse a number of the activities under one lead. It all depends on how that province wanted to do it. Now that's made it difficult in many respects, but what CHR I think was doing is they didn't know what to do. And so let's have these 10 experiments going on out there, and let's see if we come up with one model that works better than others, or do we need this diversity because the geography is so diverse and the provinces are so diverse. So who are we in the patient engagement platform? This is a picture of all but 2 of my staff who were not in the picture. And then we also have our PPAC members, the Patient Engagement Platform, Patient Advisory Council. 26 members, 13 of whom are researchers, organization representatives like the Alberta Health System, or Alberta Health Services. And we have 13 public members who are patients, family members, interested citizens respecting Alberta's diverse population, from youth to senior, from north to rural to urban, from Indigenous to visible minority, with a wide range of educational backgrounds and health systems experience. We try not to use the word representative in anything that we do unless it's organizational representation, because no one can represent anyone but themselves. And so we're very clear that we don't say, oh, we have an Aboriginal person who represents the Aboriginal. We just try to show the diversity on our committees, and that's how we depict it. So here is a number of the members of our PPAC committee. You can see some youth there, some of the older folks, and the diversity is represented even in this picture. This was at Summer Institute last year, and I'll be talking about Summer Institute coming forward. We have such a large committee because we know we'll never get everybody. And so we work with 15. If we've got 15, we can move forward on activities. And this group came up with the terms of reference for that committee, and they're all fine with that, and it works really well. They're a very committed group of people. What does the platform do? Supports researchers wanting to embed patient engagement into their research proposals. So some of the CIHR grants, some of the other grants that I'm familiar with, CREO, PRIUS, they expect you to have patient engagement. And so researchers come to us and say, how do I do it? How do I do it? Which was mind-boggling, because I've done patient engagement research all my life. But I guess that's why I'm lead. But anyway, it's interesting that a lot of these people are not relationship-oriented people with their participants or subjects. So we do an awful lot of training, we do mentoring, we bring teams together so that we can work with them to see how to facilitate meetings and what have you. So we mentor both research and patients who are ready to engage. We have competencies for engagement that, and they can assess their own readiness to engage. At what level do you think you're ready to engage? And we also look at their strengths to see how we mix and match patients and researchers together. We establish and maintain a patient family registry, which is a patient-driven online tool. Anyone in the public can join. It's very easy. We don't ask a lot of personal questions. You tell us what you want us to know. We don't go in there and look for heart patients. We don't go in there and look for people who self-described as Aboriginal. We leave it up to you. We post research opportunities, and you get in touch with us and say, hey, I'm interested in that particular research study where they're looking for some people to be on an advisory committee. And then we do the matching that way. So it's a very different tool being patient-driven like that. And we have now about 125 members who've joined, and we're doing a big push this year on that. In fact, there is a huge registry that's been established for clinical trials in the province, and they want to connect with us so that patients who want to be joined in research beyond just the clinical trial, but as members of research teams, will click onto our link as well. So we're just in the beginning stages of getting that going. We provide information through consultation, social media, online, and in newsletters, and we've had speaker series. As I said, the training, and we also work at advancing the theory, practice, and science of PE through our publications. In our education and training for researchers and patients, we have grant writing workshops, and that's not your basic grant writing. That's how to embed patient engagement in a meaningful way in your proposal. We offer CIHR patient-oriented research foundations training, and we're looking at that training being available online We've had discussions with CIHR just recently because we want a wider reach than just your urban city person going and taking this. And this is for patients and researchers, this CIHR Foundations training. Patient engagement and research plan development. We help you develop your plan because it's not good enough just to put in you're going to have patients. How are you going to have patients? What are you going to compensate them for? What are your, who's going to be the person that's going to be the liaison with those patients? We help you with that. We have just almost completed the how-to guide for patient engagement practice. It's sitting in my computer. I'm doing the final look at it before that will be available. And that is a very, very handy tool that will be something available to anyone in Canada or anywhere. Facilitating active and meaningful engagement and support throughout the research process. And we've just developed another guide for ethics, and I'll talk a bit more about that. In terms of the registry, the idea is to sustain an online group of patients to report to, gain feedback from, and share info with. I mentioned it's easily accessible. We manage our public connections and communications there, and we list the research engagement opportunities. And we've had to teach our researchers how to write their requests for patient involvement. That has been a job of one of our team members because I need 10 people to do such and such, or I need a patient on this, and we say, no, that's not how we're going to be posting it, or they post it, they send us the proposal that they sent in for funding, and it's just not going, it's going to turn patients off rather than get them excited in your research. So we provide that support to patients and help them rewrite that posting so that they're more likely to have patients say they want to get involved. I said I'd mention the Summer Institute. This is a SPOR, Alberta SPOR initiative. All 7 units come together for this. It's this summer. I just wanted to put a plug in. Everyone is welcome to attend May 14th. Well, I guess it's not summer. They call it the Summer Institute, but it's spring. Keys for collaboration. There's a call for abstracts right now. It's an interesting forum where you're mixing with lots of patients and lots of researchers, and the dynamic is really exciting. In fact, the very first time there were more patients than researchers because a lot of the researchers hadn't really bought into it, but I certainly had, so I invited all kinds of people. So there were more patients than researchers who came, and the researchers thought that we kind of took over. But anyway, not we, but the patients. We had a lot of fun, that's for sure. But anyway, it's a wonderful, if you're interested in this whole patient and researcher engagement initiative, it's a wonderful way to spearhead connections with other researchers in this event. I know BC just had their first, just a few months ago, they had their first conference. I haven't heard of anyone else across the country having a conference at this point. So what does your provincial SPOR unit offer? Check your provincial SPOR unit website, as some provide studentships, and I think as educators you really need to know about that. Our unit provides 10 studentships, and it's for students in their first year of a master's or a PhD, which is really odd, because in your first year, some people haven't even decided what they're doing yet. But anyway, if you know about it and you happen to have a keen student who already has an idea of what they want to do, they should apply. Like in Alberta, it's a $10,000 a year studentship, and there's nothing they have to produce for that. It's just to help them in that first year because they've expressed an interest in something to do with patient engagement. Some provide research funding to researchers. We don't in the province of Alberta, but many of the other provinces do, and absolutely Ottawa does more of that than the support kinds of activities I was talking about. I think a lot of it stems from the fact they have 12 universities involved in this, and that was the way they decided to divvy up their funds. Many provide webinars. There's all kinds of webinars. When I was preparing this presentation to get the logos for you, I went and explored all the different units and what they have developed over the last time since I looked at their websites. So I have a few of the websites noted here, from the ones that I could copy and paste. There is also a unit in the Yukon and in Nunavut and Northwest Territories that are teaming up with different provinces for additional support. So here's some examples. Are there any questions up till now? No? Okay. You're bearing with me in my husky voice from my cold, but anyway. So here's some examples of patient engagement and research. Alberta men identified need for information about prostate surgery to me at a party. As a result of that, I suggested that we get together and talk about what we could do. They invited me to a prostate cancer support group meeting. One thing led to the other. We got involved together in planning, in data analysis, and we took that content and we have published a booklet. It's in print and open source in French and English, has thousands of hits, and is one of the best sellers from Athabasca University Press. And I did that with two other colleagues, CASN Moore from here, and Diane Pine from Alberta Health Services. Anyway, the urologists were handing this book out, but that is from beginning to end, patient-directed and patient engaged, definitely. Example 2, Canadian health researchers recently found that people on dialysis rated itch as the #1 problem that they wanted researchers to investigate. Researchers have not heard about this concern, and now some people on dialysis are members of the research team and partners on this CKD project. Example 3, in 2 recent Alberta clinical studies, patients, public members on advisory committees reviewed questionnaires, and they provided valuable feedback that was successfully adopted. And the PI on the project, Dr. Israel Amarov, said, "Who knew you could learn so much from your clients?" Example 4, depression priority setting. Patients, carers, clinicians, and researchers were partners on a steering committee, and that is a picture on the right of some of the members of that steering committee, to identify the top 10 list of depression research questions relevant to those dealing with depression. The steering committee designed and implemented a survey to solicit questions from Albertans. It was disseminated widely by Twitter, by Facebook, by hard copy, email. Over 900 questions from Albertans were submitted, and it's taken a year for this project to be completed, and top 11 questions were determined through discussion, analysis, and a review of the literature. This just shows you the amount of attention that got in the media, because we had a media launch of our findings. And I did have a clip in here, but it wouldn't work on Adobe Connect, the clip that I had. But they focused on the patient who co-presented to the media just January 25th. And what the patient said was being involved this way in helping to determine what the questions were gave her a voice. She could advocate for herself. She was a very powerful speaker, and if any of you are interested in hearing any of that, I know this webinar is available after the, and you can click on those links. So, do we have any questions yet on anything?
Yes, I do.
Okay.
Typing this question to you. For the 10K, for the MN and PhD students, are that 10 per master's and 10 for PhD, or is it 10 altogether?
$10,000 per student for 10 students.
10 altogether.
10 altogether.
Okay,
yeah.
thank you.
Yeah. and the call will be coming out probably in June or July, and the timing isn't great at all. And they have to be full-time students, so Athabasca students, unfortunately. And I've sat on the committee and tried to argue that one, but have lost. Okay, then I'll go on and talk about ethical implications. Patient-clinician researcher collaborations are challenging many of the long-accepted traditional norms of roles and responsibilities. HREBs need to understand the nuances related to patient engagement research, which influence the boundaries of their responsibility around human subjects protection and oversight of investigators and researchers. If you have patients being considered investigators and members of the team, where do they fit? We probably get more questions coming to the patient engagement platform about ethics. The second most number of questions, that and how do I get patients involved with me? So that's why we've been developing a document that is based on a CIHR ethics document that had broad input from across the country, and ours has broad input as well and should be available very shortly. It needs to go out to graphic design. So, is the involvement of the patient active versus participation as a research subject? If it's active involvement, identifying and prioritizing research topics, being part of an advisory or steering group, undertaking aspects, some or all, of research projects, reporting and communicating research findings, well, then they are team members, and you report them as such, and you label them as such in your ethics application. I know everyone uses a different program. In our program, I just put them on not as knowledge users, I put them on as either co-investigators, depending on the role that they are playing. We all have a number of different roles that we can pick, but they should go there, not as participants. Active involvement does not generally raise any ethical concerns if there is no direct contact with study participants. Patients are acting as specialist advisors, reviewers, analyzers based on their experience. Now, there may be some who get involved with interviewing. There may be some, I don't know if any of you have heard the term PACER, but this is the name given to a program out of the U of C where they have a year-long internship, and people who are not researchers, who have lived experience of some health situation, take this hands-on program and become patient researchers. So they play a dual role. So when they are playing that role, sometimes some ethics boards who aren't familiar with them might question what they're doing. But there is no reason why they shouldn't be able to be doing this kind of work. And you don't have to be a PACER to be able to do that kind of work. You can hire someone who happens to have been a patient who you want to work as a research assistant for you. Then they become a research assistant. But if they do it as a volunteer, it's different. So you just have to work that out with your own REBs. I do know that in the United States, that institution I told you about, PCORI, they give funds to patients to do pilot studies, and if they do well in their pilot studies, everything works well, they then, and now those pilot studies I think are $15,000 last I heard, they will then give them funding to do a larger study, and they are the leads. So, and these are people without all the education and training, but many of them have learned a lot while they're doing it, of course. If patient involvement includes direct contact, more rigorous ethical review. So does the patient have the knowledge, support, and supervision to do what they're doing? So if they're going to be involved in interviewing, are they provided with training to do that sort of work? Patient researcher and patient participant need protection, so both of them. And of course, everyone is bound by the ethics of confidentiality. It is incumbent on research teams to clearly delineate the protocol's roles and responsibilities of all members, including the patient researcher member or the patient team member who is involved on your team. What are they expected to do? If you don't do it, HREBs will just come back to you and ask you to fill that in. So go in and get that clarified well first. If a patient will fill 2 roles, and sometimes that happens, where they're a research subject and a patient researcher, the rationale for both needed, as well as special attention to inform consent. It may not be appropriate, it's usually not appropriate, but in rare diseases I have seen it happen. There just aren't enough people to go around to be having some in a pool of participants and some in a pool of team members. So in that instance, I have seen them seen them engaged at all those levels. So advancing the science of patient engagement through publication of systematic and rapid reviews on priority setting, patient engagement, and patient and researcher competencies for engagement. We have just, I mentioned that those are publications that have either been published or are under review. Also through evaluation of patient and researcher engagement activities, both of the platform and the research teams to help determine best practices. We are really ramping up and wanting to evaluate what has been done by our team, what has been done by researchers in terms of patient and researcher engagement, and what has been the effect. We really need to be informing best practices. So what does the science say about PE and research? Qualitative data exists which strongly supports the benefits of patient and researcher engagement. More quantitative studies are called for to more robustly add to the science of patient engagement. We encourage all researchers engaging with patients in their studies to evaluate this engagement qualitatively and quantitatively. And a quantitative toolkit has been developed with SPOR partners across the country and is available to researchers. So early best practices, no more token patient. One is not enough. Patient members versus patient representatives, as I've already said. The role and time commitment clarity needs to be established. Mutually beneficial is necessary. Plain language use, but with the caveat that there has to be movement on both sides. Patients have to learn some of our language. We have to learn their language. It's a two-way street. And meetings held so as to respect patients' time and contribution. Now that one is an interesting one because I have a lot of difficulty sometimes getting my researchers to meetings, but I don't have trouble getting my patients to meetings. And if I don't hold the meeting during the day, if I hold it at evening or weekend for the patients, researchers often won't go. And I've challenged them about that because, you know, a lot of our patients involved with us have jobs and they aren't being compensated for their time away from their job. So you really have to think about that. If you really want to do engagement, then sometimes it has to go out of your normal work hours. Implications for nursing educators. Inclusion of patient and researcher engagement in health research in master's and PhD student research. I think you need to encourage your students to do this. And I know traditionally we all had to slave through it ourselves. No one else could ever help us. Well, I think those days are gone now. And I hope you are open to the idea that patients might be involved with your students in their research, helping with the analysis. Inclusion of patient engagement is a thread running through all courses. We really want to influence this uptake in our courses from undergrad to grad because we also have patient engagement in practice as well as patient engagement in research, and they're on a continuum. And I think we really need to be taking on this terminology. It's kind of like a steamroller that's coming down, and yeah, we just need to embrace it and give it some more than just lip service. Consider developing an MN course about patient engagement and research. We have, Newfoundland has developed one, and we are looking at developing an online one or face-to-face because I think that this is an important role and area that a lot of, certainly nurses, do this well. So they can be on these multidisciplinary teams helping with the other members of that team in their engagement efforts in larger trials and what have you. Encourage students to avail themselves of training and SPOR support opportunities such as mentoring about patient and researcher engagement. We have mentored a number of students who they would sit in on meetings that we have with our patients just to see how it actually operates. And you can check with your unit to see if that can work. Be aware of the studentship opportunities, of course. And then the final word is the parent's voice, and again it's Laura's. After the briefing on the study, the answer to the question of how can I add value to the study was clear. My voice as a parent is how I add value. Being a part of the letter study makes my voice louder. It allows my voice to transcend the ears of my children's healthcare providers to ears that would otherwise never hear it, ears that have the means to create change in the delivery and management of healthcare. I always break up over this. Knowing that my voice is heard and can make a difference is very empowering.
Thank you, Virginia. Most
Thank
fascinating.
you. Thank
really
you.
Enjoyed that. We have 5 minutes left for any questions.
No questions?
I see that we have 12 attendees at this point. Well, then now we have 16.
Okay. I do apologize. I did notice that the uploading of this changed my formatting. Anyway, it worked well on my machine, but it got translated differently.
Well, I'd like to say for the participants, this recording will be available on the CASN YouTube channel in the coming days, and please feel free to share the link with your networks. We're having the next Lunch and Learn on March 8th, Thursday, so please visit the CASN website to sign up. To you, Virginia, I love your enthusiasm. You're the perfect person for this. I know from your own experiences, but you bring a lot of credibility. But I can just feel your excitement about doing this kind of research. And thank you to me as a nurse educator saying, why don't you get a course and have this course part of your MN programming. So I'll definitely pass that along to the Associate Dean of Graduate Studies.
And maybe we could even collaborate, and you do it face-to-face and we do it online.
Oh, wouldn't that be
I
great?
think that would be the best way to go forward with it, because, I mean, this is all about collaboration. We could have some patients involved in how we should be designing it. Yeah, and I do have the template that came from Newfoundland. They graciously shared it with me, and of course we would reference them in it, but
that's the way forward.
Yeah. Well, I am passionate about it, and I appreciate the opportunity to spread that passion, I hope, and to talk with you all, and I apologize for my voice, but I'm a little bit higher in tone usually, but thank you, and thank you for your interest, and feel free to send me any questions personally if you have any, and certainly do contact your own SPOR support units to see what they have to offer you in terms of research support.
Okay, well, thank you. And
thank you.
To the people that are still online, 9 of you, thank you for joining us. Bye for